All right, good evening, everyone. We're here, we're live, and Gates Way to Health, Dr. Randall Gates, board-certified chiropractic neurologist, also a chiropractic physician. And tonight we're talking about polycystic ovarian syndrome and genetics. So, hey, Kathy, good to see you. And we'll give everybody a few minutes. Hey, Heather, hope you're doing well, to come into the discussion. As we talked about last week, I'm doing these webinar series because we want more in-depth explanations of what's actually going on within individuals. So many of you have heard about Hashimoto's, you've heard about leaky gut, you've heard about autoimmune, you've heard about glutathione, you've heard about all these things. And lots of times these presentations are generalized, so they're understandable. But the fact of the matter is that most of you have heard this stuff now. So we're trying to take it deeper. We're trying to give you more nuanced explanations so you can understand your condition at a different level. So that's what we're talking about tonight. And hi, Kathy. So glad that you said hi. And we're going to just jump into polycystic ovarian syndrome. I've done at least 2, maybe if not 3 radio shows on polycystic ovarian syndrome. And so it is a favorite topic of mine because the results are rather obvious and pretty impactful. So many times polycystic ovarian syndrome patients can't get pregnant. So working with a female who has PCOS, who's then able to get pregnant, is really one of the more gratifying aspects of what I do. And we work with a lot of different conditions as well. Hey, Jamie, good to see you. And so all of you, if you want to share this Facebook Live out to your friends and us talking about PCOS and jamming on it, go ahead and do that if you feel comfortable, and we'll just get going. Anybody else who has questions, let me know, and I'll try to be fielding them as we go through the topic. And thank you, Heather. I so appreciate you acknowledging that, us doing this topic, because we talked about genetics related to anxiety last week. We're talking about PCOS and genetics this week, and we're talking about bipolar disorder and genetics next week. So that's kind of the list that we have going at this time. So we may as well jump into it. Polycystic ovarian syndrome. Very common condition, just the overview, so to speak. 5 to 20% of the population of females has this condition. It's a very, very common condition. Manifests with 2 out of the 3 following criteria, either signs of high testosterone from an examination standpoint. So if you're getting dark, coarse hairs on your face or your chin, chest hair growth, if you have blood test signs of high testosterone, that fulfills 1 criteria. Second criteria is basically, they term it anovulation or oligoovulation, basically meaning are your menses 20 days, 1 month, and then you don't have a menses for 3 months, or you don't have a menses for 6 months, or you're not menstruating at all. Irregular cycle lengths is one other way to say it. That's number 2. And then number 3 is cysts on the ovaries. So that's the 3rd criteria. So if you have 2 out of those 3, then you can have polycystic ovarian syndrome. And it's interesting to a lot of you that you don't necessarily have to be confirmed as having cysts on your ovaries to be diagnosed with PCOS. And this is the Rotterdam criteria. You can look it up. The Rotterdam criteria has been the most widely accepted criteria for diagnosing this, but journal Fertility and Sterility in 2017, they went in, they actually studied OBGYNs, I'm not knocking them, but they studied OBGYNs and how they diagnosed polycystic ovarian syndrome and how they thought it should be diagnosed or how they were diagnosing it. And 30% of the OBGYNs would only diagnose someone with PCOS if they had cysts on their ovaries. So they weren't going by the Rotterdam criteria, which is the widely accepted model. So this is why I have so many patients who come into me who say, you know, my doctor said I don't have PCOS unless I have a beard and I weigh 400 pounds. And it's like, well, you don't have to be that far out on the spectrum to receive a diagnosis of polycystic ovarian syndrome. So just know that. And we got some other people joining. Hey, Gina, how you doing? And thanks for the wave, Jamie. Oh, Tiffany, hey, good to see you. Hope you're doing so well. So that's kind of the overview on PCOS. Now, many of you, as you start to read about PCOS, you read about insulin resistance, you read about birth control, taking a drug like metformin to help with the insulin resistance. Insulin resistance is the most common underlying factor associated with PCOS. It affects about 70% of polycystic ovarian syndrome patients. Pause there. Now that leaves another 30% of polycystic ovarian syndrome patients to not have insulin resistance, which is really important. And in my experience, lots of times these are your thin PCOS patients. And they're oftentimes confused because when they read online, they say, well, they're talking about diet and exercise and weight reduction, but I'm already there, so why do I have this condition whereas somebody else, does not? So that's kind of the story, and we'll get into some of the genetic components as to what may be going on for the thin PCOS patient, or particularly the PCOS patient who may develop the condition at a very young age, almost right as they're going through puberty, and they had a lean body mass index at that time, but their mom had it, their grandma had it. Hopefully these answers will be more clear as we go through it. And let me just scroll down. Oh, hey, Crystal, good to see you. Thanks, Tiffany, appreciate it. Not much is going on, just a little busy, and that's about it. So I think that pretty well outlines it. Common medical treatments for PCOS include the birth control, like I talked about. Femara is a very common drug that's used now. For fertility, clomiphene is used. Clomiphene basically stimulates your brain, your pituitary gland, to talk to the ovaries more and try and get the ovaries to produce more follicles and more eggs, more healthy eggs, so that you can become pregnant, because PCOS is the most common cause of infertility, in our country. And the medical management side also includes drugs like metformin. Metformin is a diabetes medication that has a lot of use for PCOS patients because it helps with insulin resistance. And we'll talk about tonight some of the downstream consequences of insulin resistance and how that interplays with genetics. And the biggest other factor that I've seen is the association between PCOS and anxiety and depression. Anxiety is a very common driving factor for PCOS because, as I said before, PCOS involves too much testosterone. And when you have too much testosterone, it may be coming from your ovaries, it may actually be coming from your adrenal glands, quote unquote, your stress glands. And so higher levels of background stress can actually drive a PCOS patient to have higher testosterone levels. And researchers thought that maybe a lot of PCOS patients have anxiety and depression as a consequence maybe of inability to lose weight, or frustrations with diet, or frustrations with their condition, like inability to conceive. And they've actually found that's not the case. It's actually physiologic. It's because of inflammation in the body, inflammation going into the brain. They think those are some of the driving mechanisms. Now, one thing I speculate that I haven't been able to find a research article on goes back to last week. So we talked about, let me say it this way, if there's such an anxiety association with PCOS, then why don't we look more at COMT, MTHFR, MTRR, all these other SERT polymorphisms, these genetics of basically warding off anxiety. Because if you have a genetic proclivity for anxiety and combine that maybe with a genetic proclivity for some hormonal abnormalities that we're going to talk about tonight with PCOS, then that might be something going on that really should be addressed as well from a functional standpoint. So I think that pretty well details it. Looks like we got some more people joining. Hi, Corinne. How we doing? Okay, so Jamie's saying, how does diet affect PCOS? Mainly because insulin resistance is totally a gut bacterial problem. That has been so well validated in diabetes and pre-diabetes. The one cure for diabetes is actually gastric bypass. So what they do is they go and they may cut out a portion of the small intestines. And we're finding that the small intestines are one of the critical areas that actually poison the liver. And the liver is where insulin resistance comes from. So what is insulin resistance? Insulin resistance is you eat a bowl of oatmeal and you're making 20%, 30% more insulin than you would have 30 years ago or 20 years ago. That's insulin resistance. You're making more insulin for the same amount of carbohydrate, which is important because so many of you go on diets, you're trying to lose weight, you can't lose weight because your body is programmed to make insulin with the drop of a pen, or drop of a hat. So that's where that's important. And diet is one of the most powerful factors to change your microbiome, to change the gut bacteria. Everybody's looking for the simple solution, looking for supplements, looking for probiotics. We're actually finding the best way to change the microbiome is by changing someone's diet. And probably the reality as to why 1/3 of our population is pre-diabetic, 2/3 of the population have weight issues, is because of abnormalities in the microbiome. So that's the story there. That's how diet affects it. Kathy is talking about cysts on ovaries since 17. Nobody ever mentioned this to me. Does PCOS correlate with anxiety? Yes, 100% PCOS does correlate with anxiety. And researchers think it's the inflammation, maybe it's the imbalance in the hormones too, because hormones are very important for brain function. So if you take a guy and he has low testosterone, that can cause anxiety. If you take a female and she has lower estrogen relative to testosterone, that can be associated with some cognitive effects as well. Oh, and then Crystal's saying, Dwayne wants to know what size. Oh, thank you. That's what I meant to do. Thank you. And Fran, if you're watching, these are the socks. These were kindly given to me by the office staff here at Gatesway to Health for my birthday. So thank you so much, everyone. Not too often does somebody stick their foot up into view. Oh, gosh. And then Kathy's saying, how does insulin resistance correlate with PCOS? Well, okay, and there we can probably go into genetics. And I want to say hi to Melissa. Hey, how you doing? Good to see you. And hi to my brother, Alan. Great to see you too. Hope you're doing well. Thinking of you today. So how does insulin resistance correlate with PCOS? So now we're getting into the nitty gritty. The ovaries and the adrenal glands make testosterone in a female. And in essence, what you need to know is that testosterone and other hormones come basically from cholesterol. And there are two major enzymes. One is the 1720 lyase, and the other one is the 17-alpha hydroxylase enzymes within the ovaries and the theca cells of the ovaries, as well as in the zona reticularis of your adrenal glands. What does that mean? Your adrenal glands are like the earth. I think I mentioned this last week. You have an outer crust to the earth, you have a mantle, with the lava, and then you have an inner core. The outer crust makes certain hormones. That's the zona glomerulosa. The mantle is the zona fasciculata, and then the core is the reticularis, and then there's a deep core, which is actually the adrenal medulla, which makes adrenaline. But the zona reticularis in a female makes DHEA. Many of you have had DHEA tested on your blood tests, and DHEA basically turns into testosterone in females. So I say all this to say, we have these two enzymes, 17-alpha hydroxylase and the 1720 lyase enzymes, that are critically involved in either making inflammatory forms of progesterone or testosterone. Insulin resistance upregulates these enzymes. So if you take a female and she has insulin resistance, so how does this actually look? You're normal, you're eating the standard American diet, you have a genetic propensity for inflammatory or obesogenic bacteria to grow in your intestines. Then pieces of bacteria start breaking off, going into your bloodstream. Think of your bloodstream getting like crop dusted or leaves blowing off of a tree. That goes into the bloodstream. The pieces of bacteria actually poison the liver. So the liver gets inflamed, you can think of it that way. It interferes with insulin signaling. So actually these pieces of bacteria have been shown to block insulin from binding to your cells. So then what has to happen? Your body has to make more insulin to get the carbohydrates from your diet, sugar, into the cells of your body, like your muscular tissue, so you can work out harder, and your liver tissue to store the glucose. So then we develop the insulin resistance, and the insulin resistance drives the ovaries and the adrenal glands through the 17-alpha hydroxylase and the 1720 lyase enzymes, so you start making more testosterone than you should. That's how it happens. Pretty dang cool from a physiologic standpoint, not cool for a PCOS patient. So now we start making too much testosterone, and that's where we develop the hyperandrogenism or hyperandrogenemia. Emia just means you see signs of it on your blood test. And something beeped. I don't know what that means. Oh, thank you, Melissa, for the comment on the socks. Hey, Steve, how you doing? Hey. So that's how the insulin resistance drives the testosterone and the high testosterone. Some research articles say it correlates with then an increased body mass. Some research articles say it doesn't. And in my experience, it tends to associate with a higher mass of muscular tissue. So many PCOS patients will kind of notice this, that they kind of have a propensity for putting on muscular tissue, particularly if they go to the gym. And what do your doctors tell you to do? Go exercise, right? So if you're a PCOS patient, you're told to go on a diet, you're told to exercise, you go to the gym, you start doing squats. It's like all of a sudden you start gaining weight because you're putting on more muscular tissue. And lots of times that's really disheartening for PCOS patients. So that's why I work mainly with cardiovascular type programs with my PCOS patients. Now going to the genetics a little deeper, we talked about the ovaries and the adrenal glands making the testosterone. We're actually finding that PCOS patients don't down-regulate the receptors for the chemical coming from the brain to tell the ovaries to basically be stimulated. So let me say it this way, more specifically, let's say it over again. PCOS patients do not down-regulate their luteinizing hormone receptors. So what this means is that the brain sends luteinizing hormone down to the ovaries, telling the ovaries to make something like estrogen. Now, as we talked about, testosterone can be produced as well. Well, PCOS patients seem to have genetic polymorphisms that don't allow them to downregulate the receptors in their ovaries for luteinizing hormone. What this means is that a PCOS patient becomes hypersensitized to luteinizing hormone. And then this can lead to an excessive production of ovarian hormones, namely estrogen or and specifically testosterone, because there's also genetic defects that involve the 17-hydroxylase and the 1720 lyase enzyme. Let me say that again. There are genetic effects in PCOS patients that drive them to almost have overactivation of the 17-alpha hydroxylase and 1720 lyase enzymes. So now if we look at this and you have this ovary where we have insulin resistance for 70% of you poking the ovary saying, okay, upregulate these two enzymes that make more testosterone. And then there can be a genetic component, it's technically through the cytochrome P450-17A1 gene and polymorphism that cause these enzymes to actually be upregulated themselves. And this is really important because we're seeing that this effect seems to have a high degree of heritability. And I know so many PCOS patients who say, my mom had PCOS, I had PCOS, I'm worried about my daughter getting PCOS. You know, she's such and such age and she's going into puberty and I'm really concerned. Well, it's largely because of these genetic factors. Now, genetics doesn't mean determinism though. And so what can we do to say, okay, we have a genetic proclivity, but what can we do in terms of insulin resistance management? What can we do in terms of anxiety management to help this young, middle-aged, older individual with their testosterone production? So that's what the new research is showing. Now, relative to the adrenal glands, there's also a sulfotransferase issue with DHEA in PCOS patients also. So many of you have heard of DHEA sulfate. Again, the adrenal glands make DHEA. DHEA sulfate then turns into DHEA, the regular form. Well, they're finding that some PCOS patients have a genetic aberration in how the sulfation occurs with DHEA. And that may be playing into why there's a genetic component for some individuals. And as I said before, if you aren't insulin resistant and if you're the thin PCOS patient, you really want to start thinking of how your brain is talking to your adrenal glands. And there may be an anxiety component. There may not be an anxiety component. There may be something called 11-beta hydroxycortisone, I believe it's 11-beta hydroxycortisone deficiency, where the female won't actually be able to get rid of cortisone, turning it into cortisol. So as a response, the brain will start sending too many signals to the adrenal gland. The adrenal gland will make too much cortisone again, which doesn't form into cortisol, and then the adrenals will make excessive DHEA. This is kind of how complicated it is, but hopefully you're getting an understanding that there can be many different pathways as to why there's a genetic association with this condition. And I'll look at questions here in a second. Probably one of the other main factors is anti-Mullerian hormone. If you listen to my radio shows, you've heard about anti-Mullerian hormone. Anti-Mullerian hormone is basically the hormone that sits in the ovaries and helps the ovaries to select the good eggs out that will become a good good egg, so to speak, for fertility. Think of pools in the basket. Think of basketballs in the pool, so to speak. So if you have a pool filled with basketballs, the anti-Mullerian hormone helps to control the best basketball coming out of the pool that will form into a healthy fetus. But if anti-Mullerian hormone is too low, if it's too high, it really messes up which basketball we pull out of the pool. And so with that, there can be genetic associations in terms of anti-Mullerian hormone production. They're actually seeing that in PCOS patients as well. So PCOS patients may have a tendency to make too much anti-Mullerian hormone. And as we become more dependent on lab tests and our current healthcare system and not clinical diagnoses, right now PCOS is a clinical diagnosis, well, certain researchers are wanting anti-Mullerian hormone to be the gold standard diagnostic for PCOS patients. But it varies between ethnic groups, and they're having a hard time creating a cutoff that will really identify all the PCOS patients. But just know if your doctor tests you for anti-Mullerian hormone, AMH as it's commonly known, that's what they're doing. So those are the main genetic factors associated with PCOS. That's basically the talk. Out of all of that information I just gave to you, they know about 10% of the problem. So we know from genome-wide association studies that what I just told you is about 10% of what we know. There's still 90% that we don't know. We don't know a lot of the individual genes that may be correlating with some of the aberrations that I just told you. So that's the complexity of genetics. We do know all the things I told you. We know those things are there, but we just don't know the specific genes. Because lots of times when people think about genetics, they think, oh, we need to find that one gene for that one problem. It's not that simple. There's multiple genes interacting to create a scenario that leads to development of a condition. So it could be many, many different genes, many, many different areas, and many different chromosomes that lead to this. And that's why, with the Human Genome Project and all of that, I remember being in high school being super excited. Oh, we finally sequenced the genome. This is going to be great. And really a lot of genetic therapies were never developed because it's far more complicated than we thought. That's not to say that researchers haven't plugged on, and they're doing some pretty cool stuff with like growing organs out of nothing, basically using genetics. So genetics, it is going to be an area of the future, and it is an area of the future for functional neurology practices like Gateway to Health and helping patients who have PCOS, because it's important to identify what you have going on. No two PCOS patients are the same. There are these different criteria for PCOS, and there are different labels for it. Like some PCOS patients have too much testosterone and they don't ovulate correctly, but they don't have cysts on their ovaries. And there are other patients who mainly have cysts on their ovaries and their ovulation is messed up, but their testosterone is normal. So each PCOS, and there are PCOS patients who have insulin resistance, there are PCOS patients that don't have insulin resistance. If you don't have insulin resistance, well, what's going on? Is it a genetic issue with AMH? Is it a genetic issue with your 1720 lyase enzyme? Or is it a COMT polymorphism driving anxiety that's then driving hyperandrogenism through your adrenal glands? So these are the things that I'm thinking. Now, how about you guys send me your questions? Hey, Fran, hopefully you saw the socks. You may have to rewind. So Corinne says, hey, Trevor. Corinne says, so if you're insulin resistant, you are a diabetic as well? No, I need to explain that better. So insulin resistance is kind of the warning stage before diabetes. It takes on average 10 to 20 years of being insulin resistant before someone develops diabetes. And think of a curve. So we have a graph here, and then we have a curve coming out this way. The first curve is sugar. So let's say you have your bowl of oatmeal. Sugar goes up, and then it should plateau. You should make an equivalent amount of insulin for that amount of sugar. But once you become insulin resistant, you make more insulin for the amount of sugar that you have. Now that can go on for 10 to 20 years, basically, where your pancreas can produce more insulin. Ultimately, the pancreas will burn out, and then our insulin production will be down here. And when your insulin production is down here, that's where doctors then have to put you on drugs that sensitize your body to insulin, like metformin, or change the way your liver releases insulin and stores releases sugar and stores sugar. And then there's a variety of other mechanisms in terms of trying to get the pancreas to still stimulate insulin secretion through other glutazone derivatives. And you're seeing a lot of advertisements for Invokana and Farxiga, the newer diabetes medications. That's what they're trying to do. But that's basically the explanation. Insulin resistance doesn't mean diabetes, but insulin resistance is kind of the pre-stage to diabetes, and insulin resistance is a major feature of something called metabolic syndrome. And you can look that up. Basically, metabolic syndrome is where your blood pressure gets high, your belly gets larger than your waist, you may have features of high cholesterol, your blood may be too thick, and you can be pre-diabetic. All right, so any other questions that you guys have? And I just want to make a comment that if you're watching this and I'm not answering a comment, it's probably because you're watching it after we did this broadcast. So just know that, and don't feel that I didn't look at your comments on this condition. So you guys can let me know if this makes sense. If it doesn't make sense, I can try and explain it in a little more detail, and yeah, we'll go from there. I hope you guys all had a really, really good day. And yeah, so this is PCOS. From the natural standpoint, what we're focusing on is really making sure individuals' anxiety levels are not too high, and helping patients with their anxiety from a natural perspective, co-management perspective. Anxiety relates to an imbalance between the fear center and the memory area. Largely, there can also be frontal lobe components. So basically, just think your fear center goes wild, and that causes the littler things to cause you to be anxious. That can drive your adrenal glands to make too much testosterone. They did this really cool study where they took PCOS patients and compared them to control subjects, and they would have them fill out a questionnaire, and then they would also have them do an examination with their OBGYN, like just a physical examination. And they found that PCOS patients, when they would check their testosterone levels, it was way higher. Their cortisol levels were way higher when they went through just like a doctor's examination. And so from that, they concluded that we do see excessive activation of the hypothalamo-pituitary adrenal axis in PCOS patients. So stress management is huge for all of you. So I think that's Susie, are Hashimoto's and PCOS related or coincidence? Yes, it's related. Depends on the study you look at. I've seen some associations as high as 43%. Others are more around the high 20%, 28%-ish. What we find is that if you take a group of PCOS patients, about 43% on the high end are going to have Hashimoto's. Now, Hashimoto's is where your immune system attacks your thyroid, as many of you know. Hashimoto's is really important for infertility too, from a number of different mechanisms. It seems that the immune component to the thyroid can be one of the main factors not allowing a female to carry a birth full term. Also, it affects fertility because Hashimoto's drives anti-Mullerian hormone to be higher as well. So there is an association there, and researchers are thinking that maybe there's an underlying inflammatory component in the body, and when there's inflammation in the body, it will actually attract immune cells to the thyroid, and that inflammation is also seen in insulin resistance. And as I mentioned, the insulin resistance drives the ovaries to make too much testosterone, drives the adrenal glands to make too much testosterone through the 1720 lyase enzyme, the 17-alpha hydroxylase. Okay, guys. Well, I'm not seeing any other questions, so I appreciate you all tuning in. Next week, we'll go into bipolar disorder and genetics. If there are any ambiguities, I'd really appreciate you just chiming in and let me know. And if I have to go into more details on this next week, I will. And also, I look forward to next week's broadcast on bipolar disorder and genetics. And I think this week on the Gateway to Health radio show, which you can access through the radio app, 9 a.m. Saturday morning in Las Vegas. I believe we're talking about thyroid issues this week. So tune in for the newest and the latest stuff. And thank you so much for watching. I'll see you guys all later, okay? We're ending live now.